Dr. Salem. How are you doing?
Great, great. How's it going over there? It's great to see you today. Join you for this Sperm Meets Egg today.
Absolutely. No, it's going really well. It's a kind of an interesting topic. What actually brought me to even want to do this topic, I was telling you I was doing a podcast on this recently, was one of our patients came to me and, kind of let me know about this case. And, they were a little bit fearful, and they were saying online that people were really concerned about this case. And so, and I don't know if you're having any issues. My first one was cutting it out there for a bit, but what I was saying is that this patient said something to me about this, and she's like, is this really something we need to be worried about? And she said there was a lot of people online saying, they made these horrible comments about how, well, maybe that's why you were infertile, that maybe, God was trying to tell you something so you don't die during, pregnancy. And so I thought, I wonder if people wonder how real the risk is to actually, dying in pregnancy. And, this thing that happened to Hailey Okula, like, which is what was so scary about it was she was documenting her pregnancy, documenting her infertility journey over 2 years, had her baby, and then shortly afterwards had to, succumb to an amniotic embolism. And so, that's kind of like, it kind of scared everyone because they're like, wow, this is someone we watched. This is someone, a real person. And then all of a sudden, she passed away. And it's a really tragic story. I as I mentioned in this podcast, that, her husband now is obviously has her kid. The kid, survived everything because it was after the delivery. And when I even spoke to people were thinking that some of the things that happened were because of the C-section. And so, these are things where I thought it'd be good for us to talk about and go like, no, it's, you can even not have a C-section. And so anyways, I thought it'd be a great topic to talk about and, at least answer a lot of people's questions. And so I really hope people do, come in today, ask some questions, and, it's going to be much better with them asking them than just you and I talking about it.
No, absolutely. I mean, I think this broader issue of safety after an IVF pregnancy is a really good topic, and it comes up very often, like in our consultations. A lot of people have specific questions about, hey, I heard about this or that. We'd love for obviously people to come on, ask your specific questions. But we'll talk about some of these, broader aspects. And I know you wanted to talk about this specific case, Dr. Amols. It was a very rare thing that happened to this kind of public figure. She was, on Instagram. She was documenting her whole story, had, a ton of followers, people that were following her fertility journey and getting pregnant. And then, of course, very unfortunately, what happened. So, yeah, I mean, maybe you want to give us some the background, some backstory there.
Yeah. So what was really interesting about her was she was a nurse and she was also helping new grads. So a lot of new grad IVF nurses would follow her. She was quite the spokesman for new nurses. She also people looked up to her from that standpoint. And so when her and her partner, had problems, they're out in LA, they started documenting this journey, and it took some time, but they were able to finally get pregnant. And like I said, I mean, this came out of nowhere. This wasn't like someone getting sick, someone who thought would be a high risk. And I think what scares people is they saw her and they're like, she's physically fit, she's super healthy, and yet this happened to her. And so this idea of, how can someone be so healthy and yet something like this happen? And I think the first important thing for people to know is that it's very unlikely, especially what happened to her. When I was saying to you, like, I remember when we got taught about amniotic embolisms, it was kind of like one of those things that we were told, like, oh yeah, this can happen. And well, what do you do about it? Like, well, pray and hope you have a good anesthesiologist with you. Because it's basically a blockage of blood vessels from amniotic tissue that gets into the maternal blood system. And, it's very, very rare. but that's actually not even the highest risk thing. I mean, the interesting thing is there's much higher risk things, like when you think about preeclampsia, eclampsia, when you think about all these other things that can happen. And really the more important thing is about, prenatal care, that, the sooner you get in with the doctor, as soon as you're pregnant, the better chances you have at being safe. So, but there are things out there, and so I think her case is more of a case to bring it to light. Not so much that case is something people need to be worried about. That case is like, someone getting struck by lightning. It's so rare. And unfortunately, there's still a tragedy behind it. But that case brings that question to the forefront, which is this something you need to be worried about? And I think one of the analogies I put in when I was doing my podcast is I said, you actually have a higher risk of dying in a car crash on the way to your OB doctor than you do of dying in pregnancy. That's how low it is. And yet you still get in your car to go see your doctor. And so it just kind of gives everyone this idea that it is a very low risk. But the way to be safest is by getting with your doctor early and then looking for those risk factors that could put you at higher risk.
I want to talk about what you just said there. That's such a great point about, staying ahead of risk factors. And I think it's such a big part of our job as fertility doctors to be responsible, kind of stewards, if you will, of that early pregnancy stage. And I think a lot of times patients, understandably, they get a little annoyed with us. They're like, oh, why are you checking all these things? That's not important to my fertility. Or, why are you giving me all this crap about my blood pressure or this and that? And the idea here, very simply, right, we're trying to optimize what's going to come next. Like, obviously, our really our primary goal is to help you get pregnant, but that's not really the ultimate goal. The ultimate goal is a healthy mom and a healthy baby. And for us to do that well, just like you said, Dr. Amols, I think it's incredibly important that your fertility doctor looks at things really holistically, comprehensively, and tries to optimize for the pregnancy that's to come before the pregnancy gets started. Now, that's a shared decision-making process too, right? Like, there's certain things that, you could always, lose more weight, and, eat healthier and all these kinds of things, but it's to a limit. And so that's the type of conversation, though, that I think we should always be having with our patients. And by the way, in this particular case, that wouldn't have made a difference. This is a freak accident type of thing. 1 in 50,000 can happen. There's really no way to prevent, as far as we know, an amniotic fluid embolism.
Correct. Yeah, and you're absolutely right. I mean, this is a very unique case. This was not a case of like, she didn't see the doctor soon enough. This was just purely an accident, but it brings up at least a point. And I feel like it's always a point we can use, and her death, at least can be used to help other women, because there are some people who can't avoid death. And you're right. That's one of the things as fertility doctors. One of the reasons why we have to be a board trained OBGYN to even be able to be a fertility doctor is to be able to look for those warning signs, to be able to, tell a patient that, hey, because you've had this in the past, we probably need to see a maternal fetal medicine doctor first, And so, it's interesting. When we were talking about that, I saw a couple of people come on, and one of them actually brought up a specific talk about that. And so I'm going to first go to Holly here, and she, this show isn't only about death and pregnancy or about Hailey's death. Hailey's death, it was purely just a point to jump off to talk about topics in pregnancy. So please feel free to call in for anything. So, hey, Holly.
I just wanted to say I wanted to come on to support you guys, because I just had a consult with Dr. Salem on Monday, and it was a really great consult. I have a lot of hope, so I just wanted to say that.
Thanks for coming on, Holly. We're so excited that you came on. Thank you.
Of course. Okay, so I have a question about endometriosis. As we discussed on Monday, I have suspected endometriosis. And I was on birth control for like 6-7 years, and it kept my symptoms at bay. Then I switched over to an IUD, and then for the past year, I have been off of all types of birth control. So I guess my question is, since I'm like none of my symptoms have come back, but is the endometrius continuing to grow now that I'm not on any type of birth control?
Yeah. So, I mean, Dr. Amols and I will kind of both weigh in here. We'd love to talk about this, right? Endometriosis, really, really common condition, affects a lot of reproductive age women. It's usually not diagnosed for a super long time. Actually, there's a statistic out there that the average woman has to wait about 9 years of telling her doctors, healthcare providers, fertility doctors, etc., that she has symptoms or has some things, and it takes them that long to actually say, hey, in fact, you have endometriosis. So in a way, Holly, like the fact that that we're suspecting at this stage that you have it, I think hopefully we're staying ahead of things, right? Because it hasn't taken that long to get there. Now, the idea with endometriosis is, generally speaking, it grows in relation to some extent to the amount of estrogen and progestin to some extent in your body, right? And so the old premise, or like the old school thinking, was always, hey, if you just stay on some type of birth control or stay on something that suppresses the natural estrogen from being there, you're taking away the fuel that kind of feeds the fire, if you will, right? The reality is a lot more complicated, because some people have like really rip-roaring endometriosis that if you just take them off of hormonal, treatment and, just kind of let them have their cycles normally, within a year or two, they can have really severe endometriosis come back. For other women, it could take 10 years or 15 years, or in some cases, it never comes back after maybe they've had it surgically managed. So what we're saying is that endometriosis has a lot of different subtypes almost. And sometimes we just don't know like what or how fast your endometriosis might come back. But I mean, what do you, Dr. Amols, weigh in here. I think there's different ways to think about that.
Yeah. I think one of the things I try to remind patients is this idea of not worrying so much about if it's growing or worrying so much about if it's coming back, but more about this idea of, is it affecting you? And what's so crazy out there, Holly, is that you have patients who I've done surgeries on where there's endometriosis everywhere, and they didn't even know they had it.
Yeah.
They had, no problems getting pregnant. I wasn't even seeing them for that. Might be some other little thing with cysts or something. And yet they have all this endo. There's other women who have like a dot of endometriosis. This is a little tiny part, and they're in such severe pain that they can't even go to work. And so I always try to look at endometriosis and look at it more as a clinical disease, meaning, is it affecting you, right? And the people it affects, it's horrible. And it can affect things like, infertility. It can affect pain with intercourse, all those different things. But I do find people sometimes get so stuck on like, is it growing again? And, they're getting worried about it. And I think the thing is, endo is always going to grow. Unless you basically get rid of all your hormones in your body, it's always going to grow. Even birth control doesn't stop it from growing. It just kind of tempers it. When you take some of these medications, even Lupron, like it brings the symptoms down, but still there in the background. There's actually a doctor who was in Arizona, Dr. Magrina, who once, kind of did a study talking about how, like, even when you don't see endometriosis, so you look in, you see nothing. But if you take a biopsy in one of these 8 places, it almost always comes back positive in people that you suspect it's with. And so it's microscopic too. So even when we talk about coming back, it's almost always there. But I always go back to that question of, how is it affecting you? And so if the only concern is, let's say, fertility, but you have no other issues with quality of life, then in my mind, I feel, don't worry so much about coming back. Let's worry about getting you pregnant then. Because your issue, luckily, is just pregnancy. Whereas like the woman who, can't even have relations with her partner, there's a little bit different now. Now my focus is on, okay, quality of life. And because the thing is, I've never met a patient yet where I haven't been able to get them pregnant because of endometriosis. What usually happens, the people that I see that I can't get pregnant with endometriosis are people I've seen after 10 years of having surgery after surgery after surgery with other doctors, destroying their ovaries, and then they have nothing left. And so they have this severe diminished ovarian reserve, 3 follicles on their ovary. They're 38, 40 now, and now I'm seeing them. Those are the ones that really are the hard ones then. But normally you can get around endometriosis and still get people pregnant. So that's the good news. If hopefully, and I don't know you like Dr. Salem knows you, but if it is just fertility, the good news is that at least clinically, that's the part you want to get past. And if you get pregnant, then who cares if it keeps growing? Like that woman who had it full in her belly and had no problems, as long as it's not causing you symptoms.
Okay, well that was very helpful, and thank you so much for answering my question.
Yeah,
Well,
absolutely. Are you, by the way, are you familiar with the Hailey Okula story? I mean, did you know about this, or was it just I happened to find a few patients who said something to me?
I know very minimal about it, just surface level stuff. I haven't really looked into it myself.
Yeah. Oh, I was just wondering because I'm like, maybe I just found the few patients who came to me and said something about it. So,
yeah.
Well, thank you again for coming on. We really appreciate it.
Yeah,
thanks for having me. All right,
see you soon.
Okay.
I do want to get to, Steve's on here. And I do want to talk about this idea about MFMs, but I mean, you agree with me when I was talking about like endo? Like I feel a lot of people get so worried about it. Like it's this, and yet for some people, other than fertility, that's the only factor they have with endometriosis. And if some people even knew how bad it is for some people, I mean, there are some women who just, I feel so bad for. Their lives are almost ruined by endometriosis. And so that's where, I get, but fertility, like I said, I don't get that worried most of the time. I mean, it's really one of those things I suspect, I treat, and usually have success. But the thing I wanted to get on with Steve is, and he brought this question up in one of our comments, was this idea of should we have people see MFMs? And I've actually had people come to me who were MFM doctors and said, you should send all of them to us. And I remember when we first started, it wasn't considered a high-risk pregnancy. And then now it's always considered a high-risk pregnancy. And again, I think that's a term thrown around a little too much. I don't think it's when we go high risk, like someone who's had preeclampsia before, had HELLP syndrome before. But what was interesting is that, when you see these studies come out all the time and they talk about how there's a higher risk of certain things happening in pregnancy and fertility patients, they're always comparing them to regular patients, not other infertility patients.
Right.
And so, I know, like I said, I thought it's a really interesting question. So I'm going to bring him on, and then I know we got some other people coming on as well. But let's bring on Steve.
Yeah, no, absolutely.
How are you today, Steve?
How are you doing?
Not too bad, thanks.
We missed you on the last episode. I forgot what it was. It was something about Canada that we were like, oh, hopefully he's coming on tonight.
To come on, but I had to keep my wife happy and go help. I remember I had to go do something, and so happy wife, happy life. And so,
I know that's a very important part. I know.
To relate back to the conversation about endo, I think I might have told you this before, but my wife, we didn't find out until probably 9 years that she had stage 3 endo. She never really noticed it until she came off the pill after we had 3 kids, which were carefully timed, and then back on the pill. When she also said, okay, 3 kids, you're going under. So I said, okay, I'll take the knife. And so then she went off birth control, and then she really started feeling the symptoms of endo. And but she didn't really focus on it. And instead, while she was going to get a sling put in for her bladder, the doctor the OB-GYN goes in there and goes, holy shit, you've got stage 3 endometriosis. What she thought was going to be like a 1-hour surgery was now a 3-hour surgery, and just everything that they had to scrape out, etc. So, like you said, some women can have, different stages of endo and they're fine to have a baby, and others, it really impacts them directly. So,
yeah, it really is interesting. Someone who's done surgery and lots of surgeries, it really is shocking that the clinical symptoms versus what you find is different. I think people forget that staging is not severity of disease. Mm-hmm. You can have someone that's stage 3 disease and have no symptoms. And you get someone that's stage 1 disease and have some of the worst symptoms on earth.
Yeah.
Staging is just a surgical staging. It's just saying how hard is it if you go into that abdomen again, how hard of a time you're going to have. And so when you hear have someone stage 4, that means, okay, everything's stuck to everything and it's going to be a very long surgery. Whereas stage 1 is, okay, you can go around and do anything. And you brought up a great question though in your message about, you know, would people benefit from seeing an MFM? And I've actually had several MFMs come to me and say, you know, I'd love to just see them as part of your workup.
Yeah.
And I'll admit, I think that's a little too much. I don't feel like they have to go to every single patient has to see MFM.
Yeah.
But there's no question there is a higher risk for fertility patients, even when it comes to birth defects. It's about 1% higher risk of birth defects in fertility patients compared to the general population. And so this idea of, you know, helping patients have a better understanding of risk. Do they do that in Canada? Is that like a common thing?
No, it's more like this has come out of, you know, I've shared with you my kind of vision of a disruptive service delivery model.
Yeah.
And to me, that's part of the reason why I think personally that fertility clinics, there's benefit in having them integrated more effectively in with a supportive OB-GYN network, both for upstream work, because your time is too valuable to be spending too much time with patients who could be dealt with an OB-GYN for, you know, IUIs and timed intercourse, et cetera. And ideally, your time is much more efficient if you have a flow of patients coming to you who are really IVF ready because the upstream OB-GYNs have done a better job there. And then downstream, if there is, you know, a need for MFM, you know, it's all integrated. And ideally, you know, in a perfect world, you'd have an OB-GYN who's partnered with you, who is seeing the full, you know, reproductive health journey for a patient, partnering with you. You still own the portion around the infertility aspect, but it's a more holistic, full circle effort. And you know, it just, I've seen that work well in some places in Canada just out of necessity, but it's not the norm. But it, you know, that's where I think there's got to be some value there.
It's definitely value. There's no question about it. And I actually send a lot of people to MFMs, but I usually am sending them when there's a known risk factor, right? So someone who had preterm labor, or pre-prom, someone who had severe preeclampsia, or even just preeclampsia, and I'll say to them, hey, get a plan. That way you're going to have less risk. My wife is one of them. First time we went through pregnancy, my wife had HELLP syndrome. I mean, you know, could have died from pregnancy.
Wow. Yeah.
We made adjustments the second time, had a plan, nothing. Went the whole pregnancy, barely got a mild, you know, gestational hypertension, and that was it. And so that was that part I was saying in the beginning, that having that prenatal care ahead of time is important. But then if you have a known issue, having an MFM make even further plans is always helpful, you know, to help prevent that. Because for me, the big one is like anyone who has lost a child, you know, in pregnancy, I feel like you have to prevent that from happening again. And that's where I always bring in MFMs, because I may know enough to have a conversation and sound like I'm smart, but in the end of the day, I don't keep in touch with all the new studies, with all the new research out there for these complicated pregnancies.
Exactly. Yeah. Yeah.
What about yourself? Do you do the same thing?
Yeah, I think very similarly. I mean, I would say that, you know, a big part of our role is to make sure that in the early part of the pregnancy, we've taken care of everything that we possibly can. And sometimes, you know, those are very easy things like aspirin for preeclampsia prevention, or, you know, risk stratifying people, you know, based on certain things. But I will say that, you know, on that same note, there are certain groups, like, for example, any woman who's above the age of 45, I do send her to an MFM, every single one. And I say, you know what, I want you to go see an MFM because they're going to have a more sophisticated conversation with you about what your pregnancy is going to look like. And, you know, the vast majority of pregnancies over the age of 45 have something. Now, that something isn't going to lead to like some horrible outcome, but it's something: preeclampsia, C-section, gestational diabetes, you know, and I want you to be ready for that conversation. And I want you to have somebody in your corner, really more than anything, so you have a team that surrounds you when the moment arises. And I think that's the way I think about, you know, using MFMs. Now, I will tell you an interesting little anecdote is I've sent, I don't know, at least hundreds, if not probably thousands, maybe at this point, of patients over the years to MFMs for a whole variety of things. And I always ask them the same question. I'm like, hey, do you have any concerns with this person getting pregnant through IVF? Never once has somebody told me no, that they are concerned. Meaning, I've never one time had an MFM tell me, no, you cannot help this person get pregnant because I am too worried about her. They're kind of like always like, yeah, we got this. Now, there are a few conditions where there are contraindications to pregnancy. We tend to know those, but I just thought that was kind of funny. No matter what you do, you send them there. They always tell you back. They're like, yeah, no problem. We got this.
Yeah, like you guys have, you guys have a strong, given your experience, that you can help deal with most infertility issues, and I'm sure they could feel that they can deal with most pregnancy issues that even if they're IVF or not.
Right. Yeah, and that's exactly it. I was going to say, I always tell patients when I'm sending them there, it's not so much I'm sending them there because just to protect myself. And, because I don't know what I'm talking about, but more because I want them to be educated. I want them to be an advocate. And so they know to be aware of these things. I had a case one time, Dr. Salem, where this patient had myocardiopathy in her pregnancy. Her injection fraction dropped down to like the low 30s, which just means the heart, just so people understand, like when it's pumping, was only pumping 30% of the fraction was supposed to. And, I told her, I said, why would you want to try to get pregnant? She almost died, and she already had a kid now. And I'm thinking for sure, no way they're going to let her go again. Right. Mm-hmm. And she goes to see the MFM and they go, well, it's around 50-something% now. And like her chances are almost a third of chance of coming back again. And I'm seeing her, I'm like, are you sure you want to take this risk? And she's like, no, I have to have another baby. It's in me. And I'm like, I'm not going to say, no, but I have to make sure she's aware of that risk. Yeah. Because that's the thing is we can tell people something's risky, but really, having the MFM who can go over the numbers and stuff is most important. And by the way, she got pregnant and did fine. So they were correct.
Well, you guys both practice in the right way, which is to really, engage and empower patients so that they can make the proper informed decisions. So
exactly. I mean, I feel that same way when it comes to, twins. Unfortunately, like, this year we've had to make an adjustment, had to, force, like most of the insurance companies are causing us to only go to single embryo transfer only. And it really is a shame because I think people should have a little bit of choice in it. And, at least here we're allowed to make them an advocate. And I'm hoping someday the pendulum will swing the other way and we go, hey, there are times it's okay, for these things. But thanks a lot, Steve, for coming on and appreciate the great question.
Let's connect up soon. And I got to make a visit when we,
I told you, we'll get that on for sure.
Yes. All righty. See you guys later.
Take care.
So, you said that, I kept thinking too, like sometimes I even ask them, like, am I sending you patients that you don't need? And they're like, no, it's good. But you're right. I keep feeling like they're going to come back and be like, what are you trying to do getting her pregnant? But you're right. They look at it and they talk to them as adults and say, yeah, you're allowed to take that risk. I think the one time you can't do that is surrogates. When you have a surrogate, that's where they can't take as much risk, and it's a little bit different in that situation because if you have someone who is, let's say, a high-risk pregnancy, and they're like, no, I'm fine going through. You're like, yeah, but there's a baby from someone else's baby that I can't have you getting sick that now hurts the baby. And so there's a big difference of my wife having severe preeclampsia and then going through or caring for someone. And that was actually a big thing we had to go through when we were going to be a surrogate for my sister. This concern of like, will it come back? And because she had one pregnancy that went so healthy and both times were twins, we're like, it's at least worth the risk. And we were going to at least try it. And unfortunately it didn't work. But I see we have another person here, Danielle. And I'd love to see what Danielle has any questions for us here. And so we'll get her on the stage. Hey, Danielle.
How's it going?
Hi. Hey, Dr. Salem. How are you?
Great to see you. How you doing?
Me too. I'm good. Long time no see. First off, I just want to say thank you both for, kind of taking on this topic. It's so unfortunate about, what happened to Hailey. And, as soon as I read that story, I sent it to my husband. So Dr. Salem, as you know, I'm in the military and I plan for everything. And I think that, fatalities in pregnancy is something that is not, talked about. And I mean, there's so much, especially when you do IVF, right? There's so much anxiety and buildup while you're going through the process. It's just one of those things that you just don't want to think about. And because I am a planner, I think, just the military has made me that way. I want to make sure that my family is prepared for whatever happens, in labor and delivery. Now I'm healthy. It's kind of funny that you all were just talking about the use of the MFM because I feel like in the military, as soon as you say you went through IVF, they immediately say, oh, you got to go to maternal fetal medicine. They will still treat you, on the military installations. But I think it's just one of those things because it's still one of those things that the military is just not familiar with. They do offer it, but it's just not one of those things that they're familiar with. So I have been, I guess, fortunate that I'm not only seen on base, I'm also seen off base at an MFM. So I'm 35 and older, as well. And I feel like I have probably been seen by some sort of doctor quite often, not only, from being, with IVF, but so I do kind of feel fortunate. I think that, I have been able to have the ability to see, so many doctors leading up to, because I'm going into my third trimester now, which is definitely a blessing. But I do want to kind of talk about or ask you all, because I think one of the reasons I am so prepared is because the fatality rate amongst African American women seems to be higher than that of other races. Now that could be for so many different reasons, right? Access to care, exercising, lifestyle. I mean, just so many things across the spectrum. And I think that it's important for women, kind of just like you all have been talking about, to know what those risk factors are, and I just don't think that within this journey, especially in IVF, it's something that doctors really want to dig in and to talk about to prepare their patients. So I just want to thank you both for coming on and really bringing this to light because you just don't know what's going to happen. That's just the reality of it. You just don't know what's going to happen. And regardless of, what community you identify with or belong to, I always think that it's a good idea to be prepared. So, I just wanted to say that I appreciate you all, opening up this forum to at least, talk about it.
Yeah, no, thank you. Thank you so much for coming on and definitely voicing that, that concern, that opinion. And yeah, I mean, Dr. Amols, do you want to get started here and kind of say it? Yeah.
Well, so Danielle, I'd love to know just from your point of view as so a patient, what do you worry about? Like when you hear about this, does it scare you? Like, is this going to happen to me? Is it more of like, do I need to, as you said, prepare? And has anyone done any of the preparation for me type of thing?
I think for me, it's more about, again, I've had a healthy pregnancy. So it's more about the advocacy when I go into, and I think you all have heard this too. It's all about the advocacy when I go into the room, right? Am I surrounded by the right people? In the military, one of the things that we can't really help, and it depends on what kind of health care you do have. So I have TRICARE Prime. And so I'm a little limited in that, if I am seen or I deliver on a military installation, I go into labor and delivery and don't know what doctor I'm going to get. Right. So we are kind of, cycled around amongst the doctors and, whoever is on call and they're the ones that are going to, deliver your baby. And so there's a little worry, with that. But again, my concern really going into it is having somebody, that person in my corner, if they're not, my significant other, who is going to be in the room to make sure that what Danielle wants, Danielle's going to get, regardless of the condition that she is in. And I think, at least what I've, read, and again, I'm not a medical professional at all. A lot of the, one of the issues within the African-American community is just making sure that you have an advocate. And so for me, that has been extremely, important to make sure that I've got somebody in there who's, by my side, who knows what I want.
Yeah, last week, no, not last week, 2 weeks ago, we actually had a show with Dr. Amanda, and it was about this topic, and you kind of hit the nail on the head. Is what we find is in some of the minority communities, there's a less access to care, less prenatal care. That's a big one. And then even just that idea of like, is anyone going to be an advocate for me going in there and stuff like that? And so that's where we see some of the higher risk. And then, there could be other things that, like I said, it's a very complex issue because there's multiple things. But yeah, we talked about that. And I think it's always important to know that you always have choice. When I was back at Mayo Clinic and in Rochester, Minnesota, we had a very large Somalian population. And there were times where, like, even though a C-section was needed, they would refuse it. And we couldn't say, like, no, you have to.
Yeah.
And so, I mean, you do have choice. Now, I think it's always important to keep in mind that people should be at least being an advocate for you and always trying to give you the what's best for you. And so you always take that, and then that's why it's important. Unfortunately, you don't have that situation where you get to just have the doctor you've been working with that you trust. But, they should be making the best decision for you. But back in that time, I remember there were cases where, like, we were worried the baby was going to die. And so we had to go get court orders sometimes to even just do a C-section on someone. Otherwise, the patient, the baby may die.
Wow.
And that's how much choice you really have, is that you can always do what you think is best. And you always talk to the doctor, but I always tell people, do your research beforehand, look at things, do what you want to do. So when you're coming in, it's not just them saying it, but coming on shows like this, learning about things, and know your choices. The good news I can tell you, as I said in the beginning, the chances of actually passing away is very, very low in pregnancy.
Right.
And especially with Hailey Okula, that was a very unique situation. But I'll tell you, it's not zero. And when I say it's not zero, my wife and I, we truly actually wanted more kids. And after our last pregnancy, when we got older and we were thinking about trying again, part of me believed in this idea. I'm like, well, why even take a risk? I'm like, well, at this point, we're happy. We have a happy family. And so it's not zero. And so do I think anyone should not have kids because of it? No, never. But I also feel like, it's important to know, are you a high risk person? See an MFM, see a doctor, so you can make that choice for you. And so we were older. And at that point, I'm like, there's more risk. And we've been very fortunate. God's blessed us. We haven't had, any kids with any issues and stuff. And so we felt like we're going to stop. And, I didn't want to potentially lose my wife or anything like that. And so that's why we decided to stop. So,
Right.
Yeah, I think your point, Danielle, is such a good one and such a valid one. And there's two parts there that I want to like make sure we unpackage here. The first one's just this idea of, preparedness and being prepared. And, you're obviously, in the armed forces and the military. And so you are very, very much of a planner, and so you're always making, contingency planning. And that's the way actually obstetric works, is that you're always thinking, well, if this happens, I'm going to do this. If this happens, I'm going to do this. The key part, though, is making sure you got somebody in your corner that knows you, that, hey, have you had an increase in your blood pressure? Have you had this? Have you had that? And that kind of longitudinal care with one person, generally one person, sometimes one team that really, really knows you well, makes a huge difference, so that you feel like, that, you trust them, but that also they trust you, that, if you're telling them something, they hear you. And the big example that comes to mind, especially now around your second point, which is this disparity among, the African-American community, minority communities, is, so I'm a big tennis fan. Serena Williams, a little while back had a baby and was at a very fancy hospital in Los Angeles, and kept telling her medical team that she had these symptoms, and they weren't hearing her. They were like, oh, it must be this, or you're just tired after the delivery or whatever. And she had a pulmonary embolism. And it wasn't until much, much later that they finally caught it. They caught it kind of late, to be honest. And then they started treating her at that point. That was, potentially, life-threatening complication. Now, fortunately, she did just fine and recovered and everything. But this gets back at this point that, even Serena Williams, the most successful tennis player in history, all this kind of stuff, right? Even at her level, there was a point where she couldn't get people to really hear her out for a second. And nobody knows what the exact story is there. But at some level, that's what happened. The objective fact is she had this undiagnosed thing happen. And the objective fact in America is that we see a much higher maternal mortality rate among African-American women than white or Hispanic or Asian women. Actually, I think it's about 5-fold higher between Black women and Asian women. That's not biology. That's not biology. That's something else. That's this, So again, when you say I want to be a planner, you're thinking about this exactly right. And I think if you yourself are asking all the right questions, preparing for things, hey, do I have a high risk condition? Or, I have preeclampsia. What does that mean? What can I do to impact that? These kinds of things, being proactive from the very beginning of your pregnancy with your fertility doctor all the way through until the day you deliver it. That's wonderful. Different people like to use different types of advocates too. I mean, as OBGYNs, sometimes we feel conflicted about this, but I've seen people coming in with doulas, right? And I think sometimes they have a lot of great input, honestly. Like, they understand it. They've been there before. Like, most people that are delivering a baby, they'll do it once or twice or 3 times in their whole life. Doulas are doing it, every week. Some people, have a really long conversation with their doctor about, their pregnancy wishes, right? Or kind of, making a birth plan, putting a birth plan together and talking it through with your doctor before you get to labor and delivery. Because sometimes the doctor looks at it and they're like, oh, you don't want this on here because it's going to hurt your chances of having a healthy delivery or something like that. So there are some things that I think are very much things you can control as you're going through this process, to definitely mitigate, even though it's a low rate overall, to mitigate it even further down.
Right.
And I would say, listen to yourself. One thing that is amazing is women have such intuition. I mean, I've seen people come into my clinic, worry about something, they're right. And so that's the thing I always tell patients: if you're worried about it, you have 2 lives in your hand. You have your life and the baby's life. So never be afraid to call the doctor. Never be afraid to go on in the triage. Listen to yourself. And if you think there's something wrong, speak up and let them know. So.
Well, thank you so
Absolutely.
much, for taking my question and, for just creating this platform and addressing, a lot of the concerns that women have within, our community. You both are amazing, and I do love tuning into you when I can. So, yeah, thank you so much.
Thank
Well,
you.
we love
Thank you
giving
so
the
much.
opportunity for people too. So thank you for coming on here and showing people they can come on, just ask any of the questions they want.
Yeah, for sure.
There was a question that came up. Someone was asking about that. We spoke earlier about preeclampsia, and they asked, "Do we find that patients who do IVF have a higher chance of getting it, and could you get it multiple times?" And so, obviously, yes, you can get it multiple times. I was mentioning about my wife. We were actually very afraid. She had the severest form of preeclampsia that was available, and she didn't get it again. But what do you have to say about it, Dr. Salem, to that question? Like, patients
Yeah.
with IVF, I know we make them sign consents, but what do you tell them about the risk when they going through fertility?
Yeah, no, definitely. So I've written a lot about this. This is like something that's near and dear to my heart. And, one of the things that I really enjoy doing is writing, about these type of topics. And pregnancy and safety and, after IVF is one of those. And the big message here is generally that if you compare women that have any fertility issue to women that have never had any fertility issue, you see that no matter how they ended up getting pregnant, the women that had some fertility issues have a higher risk of all kinds of things, preeclampsia, high blood pressure, a little bit of a higher risk of preterm delivery, etc. They're slightly higher. They're not drastically higher. But then if you take the group of women that have infertility issues and you compare them internally, those that got pregnant with IUI versus those that got pregnant with IVF, generally speaking, the rates are the same in terms of things like preeclampsia and gestational diabetes and, early deliveries, preterm deliveries, C-sections, etc. And on top of that, the most what we call modifiable risk factor, or basically the thing that we can actually impact the most, is if you had one baby or if you had twins or more. And if you have just one baby at a time, that reduces your risk of preeclampsia, of all these things, more than anything else that we can do, going from 2 babies to 1 baby. So I think the learning lesson here for pregnancy safety is the healthiest way to get to a healthy mom and a healthy baby generally is with a single baby at a time for most women. Now, are there, I'm sure somebody's going to call in and be like, my sister had twins and she made it to term and she was like, running around. And that is absolutely true. Some women are amazing at, somehow carrying twins, and it's a genetic thing probably. And, but for the average person who's pregnant, the average woman who has, a twin pregnancy, her rates of preeclampsia and everything is going to be substantially higher than if she had just one baby. But, and then the other part of this, of course, is that we can help impact or lower the risk of preeclampsia. One easy example is starting aspirin early enough. Good studies showing that, hey, we can really impact that risk of having preeclampsia by doing this very, very minor intervention. There's a lot of other things we consider when we go through this. But Dr. Amols, what do you consider and how do you answer that kind of question?
Well, just so we don't get hate mail, you said some women are amazing. I'm just going to say they're all amazing so we don't get hate mail, okay?
Okay, I didn't mean that.
Anyone who's willing to, carry a baby for 9 months is pretty amazing. I like carrying my backpack all day when I'm at Disneyland, and so I want someone else to share it. It's interesting because you're right. There's, I think a lot of times people are comparing people who are infertile to the general population, and you just can't do that. There's something different about people who are infertile, but it's such a broad spectrum that clearly we know there's some differences, right? Someone who has PCOS that has, going to have metabolic syndrome is going to have higher risk for gestational diabetes than someone who has sperm factor infertility, right? So the great thing is they're looking at this all the time. We're always looking to see, if there's any higher risk categories, and I think there are. I think eventually, if you break it down, we could find certain categories are higher risk than others. What's really interesting is they're still doing more, research and trying to figure out what's safer. And one of the things I thought was really interesting is at the last conference we were at, they were talking about in Europe, they're actually trying to go to these, modified, like this. It's a new way to do natural cycles. Now, again, I'm not trying to get everyone to do the natural cycles. That's not the purpose here. But they were showing, and I think we lost Dr. Salem for a minute, but he'll be back. What they showed in this is that people had lower risk of preeclampsia. And so does it mean everyone should jump to that? No, it wasn't just doing a modified natural cycle. It was a very specific type. But there does appear to be some type of, idea that even the type of stimulation can affect getting preeclampsia. So I thought that was just really interesting when we were at Pacific Coast Reproductive Society when they talked about that. And again, I don't think it's prime time now, but it does show that there is some things we are doing that might be bumping up. Here's the important part I think people should take away. And that is, it sounds scarier because you're getting what's called a relative risk. But that's not the same thing as absolute risk. And so when you hear something like, well, if you do this, you have a 70% higher chance of getting something, that sounds really bad. But if something's only 4%, and it's 70, now it goes to 7%. And so it's not as bad as it really sounds. It's a very small increase. And so it's important to understand the difference between a relative risk and an absolute risk. So my favorite example I tell people is if something is 500 times greater, that sounds really bad. But if it's only 1 in a million, well, then it's 500 in a million. So it's still a very small number. But yeah, I mean, there's definitely a lot of research going to this. I think healthy baby is one of the most important things. And you're right. You hit the nail on the head. the number one thing that we can do to make it healthier is, single embryo, single pregnancy, for sure. That reduces the risk of almost everything. My favorite thing you always hear me say is when people ask me, what are the risks of twins? I said, well, it's much easier for me to tell you what aren't the risks. The two risks you don't get with twins is you don't get big babies and you don't go late in pregnancy. Everything else is higher risk with twins.
Yeah.
And that's an easier way to say it because it's true. Everything is higher risk.
Yeah, that's true. That's true.
So I see, well, at least I know we had Crystal here in the background. She's going to be coming on. So I'd love to see what questions she may have for us. Hi, Crystal. How are you doing?
Hi, good. Okay, sorry. I have my Bluetooth on and my phone being charged. So it's not really a question, but it actually is concern for me because I remember when I was trying to get pregnant, I remember when I first met Dr. Amos, Dr. Amos was like, he was worried about me, but he was like, I'll only transfer one embryo into you because of your condition and because of your heart and everything and how, everything can go wrong with my pregnancy. So I don't know if that, I know that has something to do with death after pregnant or death with pregnancy, but and I know about Hailey's, I think that's her name. But I've been following a little bit of it, and it just makes me think now, what if, if I did ever get pregnant, what if that was me? Now I'm glad I'm going through surrogacy and, trying to have somebody else carry for me rather than me risking my life. And even my husband, one day was like, I don't want to raise a baby without you, if that does happen. So.
Crystal, I don't know if you're okay with me sharing. You shared it once before on live, but do you mind me explaining why you're at risk?
Yeah, no, go ahead.
Yeah. So, Crystal, as you mentioned before on the show, you have a mosaic Turner's, and people who have Turner's have a higher risk of aortic dilation of their heart. They have higher risk. There was one study that's shown even as high as a 50% increase or something in death for people who got pregnant in this situation. And so, matter of fact, one of the things we did is I had you see a maternal fetal medicine doctor. And that was one of the things. Yeah. And they went and they looked at your aorta. They made sure to look at this, how wide it was, all those things. And as Dr. Salem said, they did not say no. They're like, yep, she can go through. And but it was still, I told you to go because I wanted you to be an advocate for yourself. I wanted to make sure that you knew what your risks were. And, I'd love to hear your view on that. I'm not sure as a patient, when I said, hey, I really need you to see this doctor, was it more frustrating for you? Why won't you just let me have a baby? Or did you find it actually very educating and empowering because you were able to know more and making decisions, with that information?
I did actually find it more educational, more informative, and actually more comforting. Because then when I went to the MFM, I actually took my donor who donated her eggs to me. I took her with, and we sat down with the MFM, and the MFM was going through everything. And I'm gonna share this rare moment, and this is probably funny, and I'm not trying to be mean to anybody or anything, but the movie Twilight, I'm obsessed with that movie. But during one of the Twilight movies is where she has a baby and then she passes, and all that. And I even told the MFM, I'm like, well, I can do that. I can come back. And then the MFM just shook her head. She's like, no. Even my donor's like, Crystal just slapped me on the head and she's like, dude, wake up, smell coffee. That's not real life. So, but I got my dreams,
So knowing that there was the risk, I'd love to know inside your decision making, what made you still want to try? And again, I say that obviously I love having my kids and, I would take risks too, but we're talking not just risk of a problem, death. And yet you still wanted to do it. You didn't lose any conviction to do it.
Nope, I'm a fighter. And for one, I grew up, I did have health issues, but nothing with the heart. Never had my heart checked until I went and saw you. Never, I was in the hospital with pneumonia when I was in second grade. Just little things like that. It doesn't scare me. And just going through the pregnancy, I mean, yeah, it scared me, but it makes me more excited. And then it's like, I got this. Like, I'm strong enough. And if you just put your mind to it, I mean, like, even though with Hailey, the girl that just passed. So I know you said that she was a nurse, and it's just, and she probably knew all like the risks and all that and went through everything. But I just doesn't, I mean, like, I don't know, I just felt like it was, worth trying and not giving up. Like, and I'm in a bunch of Turner Center groups too, and I hear about everybody had babies. So I'm like, hey, why not me? So
Very
Well, thanks
cool.
for sharing that. I appreciate that. Any questions you have for us?
no, not really questions, but I just wanted to discuss on like my condition holds, like, the death and the pregnancy and everything like that. So
Thank you for sharing that.
Just one
you're
little,
welcome.
maybe if I can ask Crystal one more question, if that's okay.
Sure.
So Crystal, I mean, you were saying that, at some point you had that MFM consult and you felt like it was very like, revealing for you, or like it gave you a lot of information and it felt very empowering for you. Was there at any point did the MFM try to like discourage you from doing this or anything of that type?
No, she
Yeah,
was just like, as long as you know the risks, as long as you know what you're going through. I mean, and we look at your levels, we look at everything, and I mean,
that's wonderful.
I don't see a problem, what that they said, but
And sorry, Crystal, go ahead.
no, you're fine. Go ahead.
I was just gonna say, like I think when I ask a lot of my patients, I think what they're almost worried about with going to an MFM or getting another person's opinion is they're gonna be like, oh man, that person's gonna like disqualify me from letting me go through IVF or something like that. And it really, I gotta tell you, I've never seen that to be the case. And so I think most of the time it's very, very empowering, educational. It's putting a whole team around you. This goes back to many things, the Mayo Clinic model, of course, of having multiple experts all weighing in on your care together. So yeah, just very happy to hear your perspective, and thank you so much for sharing that.
Oh, you're welcome. And also really quick, when I'm in my TS groups, I also get a lot of girls that are like, oh, I can't have kids. I'm not going to because I have an what's called a the aortic bicep, where I can't pronounce it, but where they have to get
Tricuspid
surgery
aortic
on.
valve?
Yes, that's the one. And they're like, no, I can't have kids. And they even go to like see the fertility doctor, and the doctor's like, no, we can't do that. And and then I see other half of like Turner Center people, and they're like, oh, I had a baby through IVF, or I have a 6-year-old through IVF through 6 years ago. And I'm like, well, I haven't had any issues. I went to the MFM. My fertility doctor said, we have conditions and we have rules, but hey, it's worth a shot. So
Well,
that's
thanks
just my
again,
whole
Chris.
theory. That's all my theory on it. Sorry. So
Well, you have a great night, Crystal. Thanks so much for sharing that with us.
you're welcome. Bye, guys.
Bye-bye. I think you brought up a good point here, Dr. Salem. And the point is, don't be afraid to see one. They're not going to tell you no, but what they're going to do is make a plan. And that plan's going to make it safer for you. And that's what they did with Crystal. They came up with a plan so she could feel comfortable that things go fine. I know we're coming near the end here. And I think the one thing I want to talk about, and I saw a couple of messages on here, and I think it brought up a really good point. Malparis too, she wrote, I had twins and didn't get it until postpartum. She was talking about preeclampsia or eclampsia. Mackenzie Johnson, by the way, she writes here, which she says, I'm a uterine inversion survivor here.
Wow.
Not nearly as terrifying as AFE, but up there in maternal mortality. Well, first of all, I want to say, Mackenzie, so thankful you're still here. That is actually a very scary situation. I've actually had it happen once when I did a delivery, and it is one of the scariest things when a uterus inverts out. And so it bleeds. You can actually bleed to death. And it doesn't matter. Like, you could be, Arnold Schwarzenegger. You can not just push that thing with force. It's not as easy as it sounds. That uterus is very strong. And so the thing about these two cases are this idea that it's just in pregnancy that's dangerous, right? So in the postpartum, there are some things, such as one of them is preeclampsia deaths. I mean, that happens all the time because no one's thinking about it, and then it happens. At the time, hemorrhage, a very big, large cause of death. That can even happen within 24 hours later afterwards, start bleeding because the uterus becomes soft. But the other big one is, and I think you and I, we really focus a lot on this when it comes to mental health, is in the postpartum depression. And there are many deaths in the postpartum part because of depression. So, I think it's important to understand that this is where, again, we talk about that care, that prenatal care, always going in. And so if you, your partner, think that things are, not looking good, or you have any intuition that you're bleeding heavy, get back to your doctor. That's what they're there for. They can help diagnose these things. But it isn't just during pregnancy. I think we were talking a lot about that and the risk, but even afterwards, there are still some risks out there that, it's important to have a team around. And so that's why when you talk about midwives and you talk about family doctors, they only take on those cases that are very low risk. And the reason why is because if something goes wrong, there's not much you can do. Like that inversion story. If that happened in, let's say, at home, that would be very difficult to fix. And that could potentially end up deadly. And so thank goodness McKinsey is here with us still. But anyway, I just thought, I know when we're in training, we learn a lot about during pregnancy, at delivery, but there's still a lot of things that happen after.
Yeah, no, absolutely. And your point is such an important one. And, there's a lot of these platforms that are going up now that are integrating more and more and more of this, that are trying to integrate pre-pregnancy, pregnancy, post-pregnancy, access to people sort of all the time to discuss these things. We try to make ourselves as available as humanly possible, with any kinds of, things of that kind through our clinic, of course. And I think that the big thing here is access, being able to know how to access in an emergency setting your healthcare team too. It's such a good point.
Yeah. Yeah. And like I said, I mean, as we talked about in the beginning, even including the postpartum deaths, you have a higher chance, as I said, of dying on the way to your appointment in a car than you do of ever having a death from pregnancy, even in the postpartum when you add them all up. So it is still fairly safe, but if you're concerned about it, go see an MFM. They're going to definitely help you understand those risks and make you feel comfortable. So,
yeah.
Well, thanks, Dr. Salem. I really always appreciate going on. I know we have some really good ones coming up here, in the future. We're going to change our website so that way you guys can actually see what's coming up. And then, if you want to come on the show, you'll be able to be prepared for them. But we have some really exciting guests coming up. And so definitely keep checking in on us. Check out our website. We'll make those adjustments.
Yeah. Wonderful. We'll see you soon.
See you soon, man. Have a good one.
Bye-bye.